All right, everyone, welcome back. This is part 2, diabetic drugs. We left off on slide 49, so please listen to part 1 before you listen to part 2, unless you don't want to. I mean, whatever. You can listen to them in the wrong order. I'm not the boss of you. No. Okay, so first off, we have the sulfonylureas, also sometimes classified or called secretagogues. For testing purposes, for me, just worry about sulfonylureas. I just put that up there because you may see that in some other textbooks. Or it gets a little bit confusing though, because there are some other medications that are considered secretagogues. So for testing purposes, for me, sulfonylureas, you'll be good. We have a first generation and second generation list here. As usual, I want you guys to know which ones are first generation, which ones are second generation, because the second generation are going to be the better drugs as far as tolerability, adverse effects, etc. And so those are going to be the ones that you guys will probably be coming across and probably be prescribing. So second generations are pretty popular. They are, for the most part, generic and cheap. So they have, and they're preferred versus the first generation, like I mentioned, less adverse effects and also less drug interaction. So those are some advantages and why you probably want to stick to the second generation. The tolbutamide of the first generation is the one that's going to be used or can be used specifically for the elderly. It's not as potent. You don't have to worry as much about the hypoglycemic effects, which is preferred in an elderly population. And it's going to be the only one you're probably going to come across as far as first generation is concerned. Mechanism of action, read through this, but basically I always think of this, or the way I remember it is that these medications they squeeze the beta cells of the pancreas to squeeze out insulin. So they stimulate the release of insulin. And you can give them by mouth. So an advantage over the insulin that we talked about previously, because people don't like giving injections or taking injections and stuff. It is a PO medication. It does, one of the things that kind of its limitation is related to the mechanism of action is it can cause what you may have heard of in your other courses or in rotations, etc., called a beta cell burnout. So basically it's kind of like, again, like I like to think of that squeezing an orange. You can squeeze the cell like an orange and kind of get the orange juice out of it, but eventually you get, you hit a dry spot. You can't get any more orange juice out of that orange, no matter how much you squeeze. So that's what you may hear with these sulfonylureas, beta cell burnout. So it's basically, these drugs are good, and they are used. They're not always first line unless there is, some economic considerations to be taken into consideration, because they are cheap, generic medications. But because they kind of have, there's a limitation to them, I guess is what I'm gonna say, because of the potential for the beta cell burnout. So it's basically, again, like I said, you can squeeze this beta cell or you can stimulate it only to a certain point, and then eventually it stops releasing insulin. Hypoglycemia, as far as adverse effects, so definitely put a star by that. And it's going to be a theme here with all these anti-diabetic drugs. Hypoglycemia, so that's definitely one that you want to be mindful of. And it makes sense when you're thinking about, these drugs, you have a person who has hyperglycemia and that you may, overshoot with hypoglycemia. Also have to be concerned with the disulfiram-like reaction after you ingest alcohol. So this is where it's a very painful reaction. I believe I've described to you guys in the past. Reach out to me if you're not familiar with the disulfiram reaction, but basically a very uncomfortable, very painful reaction. So it's not recommended to have take alcohol while you are taking this medication. And just in general too, alcohol is not a good idea for people on any of these anti-diabetic medications because it can cause hypoglycemia. So again, potential to kind of increase that adverse effect. Another thing to note too is that because of the chemical structure of the sulfonylureas, you do have to be concerned with the sulfonamide reaction. So if a person has a true type 1 hypersensitivity to a sulfonamide medication, so quote unquote sulfa allergy, these medications should be avoided in those patients. So please note that for testing purposes for your boards, etc. Also have the potential to cause SIADH. More so with the first generation than the second generations, but that's still a concern. It's more rare but serious adverse effects. And then drug interactions. So put a star by that as well. I mentioned it's relatively better with the second generations, but for the class as a whole, sulfonylureas is going to be one of those classes of medications that I want you guys to associate with drug interactions. So definitely for testing purposes, for your board exams, etc. When you see these medications, think of drug interactions. They're usually not horrible drug interactions in the sense that they don't automatically kind of kill you or whatever. One thing that can happen with any of these anti-diabetic drugs that I definitely want to note, and it's related to the adverse effect of hypoglycemia, is that there can be a synergistic effect, right? We've talked about synergy in the past, but when you have additional, more than one medication that can cause hypoglycemia, or the patients on, a couple of these medications, then you have an increased risk of that. So that is one type of drug interaction, but then there are other ones too, and mainly it usually affects the dosage that you pick of the sulfonylureas, and so you may have to increase the dose of the sulfonylurea or decrease the dose of the sulfonylurea depending on the drug interaction. So please note that when you are studying. Next up, we have another type of secretagogue, Meglitinides. So for studying purposes, please, put them as Meglitinides. But the secretagogues, again, depending on what textbook you look at and stuff, etc., they are similar to the sulfonylureas as far as they also kind of stimulate the beta cells. So go ahead and read through that. The advantages over the sulfonamides is that they do not have the same chemical structure of the sulfonamides, and so you do not be concerned if a patient has a sulfa allergy. So these are safe to take if a person has the sulfonamide allergy. And then these are usually used as adjunct, typically not first line. We're going to go through the pharmacotherapy lecture and kind of give you an idea of what's first line, second line based on the ADA 2017 recommendations. So stay tuned for that. Sorry, I'm trying to drink tea here so I don't cough and spit all over your mic and in your ears and everything. Anyway, so we have a couple of these medications here. Brand names in parentheses for studying purposes. Just, I will only have the generics on there. But, part of the reason I put the brand names with some of these anti-diabetic medications is because this is, I feel like, what you hear them being called a lot in practice. So, but anyway, so just FYI on there. Bigonide, next up, Bigonide, Metformin. This is a huge player. This is usually first line when you go to your oral medications. Again, we'll talk about that a little more in detail. This is kind of a foundation drug with your type 2 diabetic patients. Definitely make sure you study this. Definitely going to be on the exam, be on your board exams. You see it on rotations, and you're going to be prescribing it for your patients, definitely in the future. This one does not stimulate insulin release, so it's not a secretagogue like we had before. It's actually euglycemic, and so you don't have to worry about the beta cell burnout, so that's good. It also improves glucose tolerance. It doesn't increase weight gain and actually can have a positive effect on weight as far as it can actually cause weight loss in some of your patients. So that can be advantageous there because a lot of times, not always, but a lot of times your type 2 diabetics could benefit from weight loss. So this may be able to help them out. One note though, I have seen these being prescribed for weight loss only in a type 2 or in a person who does not have diabetes. There was actually a psychiatrist up in Oklahoma that was doing this, and I called him about it, and he said there was some literature on it or whatever. But for my course and for your boards, etc., it's not an off-label use or anything. So yes, it's beneficial for a person to lose weight, but it should be used in a person who has diabetes to help lose weight, not just as a general weight loss medication. So hopefully that's clear. Other thing too, can help reduce stroke, heart attacks, so the macrovascular complications. It does have a beneficial CV, cardiovascular effect. So a lot of benefits there going on with metformin. Here's just the mechanism of action in a little bit more simpler terms. I try to give you guys, when I feel like the mechanism of action can be kind of complicated or students have had problems in the past, I kind of try to reword it, simplify it a little bit. So hopefully this is a little bit more simplified mechanism of action, hopefully helped you guys for studying purposes. Uses, like I mentioned, it's a foundational drug for type 2 diabetes, can be used for gestational diabetes and also polycystic ovary syndrome. But But anyway, but your big one, like I said, is type 2 diabetics. You're going to be seeing this for a lot of them. Adverse effects. Lactic acidosis, put a star by that one. That's a rare but serious one. There is a box warning related to that one. Other than that, it's usually well tolerated. Definitely read through these other ones here. GI adverse effects are probably going to be the most common adverse effects that you have your patients complain about. Make sure you look at all those. And like I said, definitely put a star here. Lactic acidosis, one of those rare but serious ones. It is one that has been kind of controversial, so not going to get too much into it, but as far as, you may hear some conflicting data, or rather some physicians saying, oh, it's not that big a deal, don't worry about it, and other physicians, no, it's a big deal, you need to worry about it. Long story short, for testing purposes for my course, it is still a documented FDA US box warning, so please study it, please learn it for the exam and for your boards, and please still think about it when it comes to your patients. But like I said, there's still, and the other thing is too, they still are doing research. There's newer studies coming out that are saying it's not that big a deal, it's really rare. But anyways, I still feel like you guys need to know the rare but serious ones. And it's a box warning, so at the end of the day, it still is something that the FDA feels like it needs to warn practitioners about. So please go ahead and read through that, because there are some risk factors here, specifically, that can make this worse. So your elderly people, people that already have maybe some other liver disease, or if they are alcoholics, maybe, etc. So read through that. Renal impairment's another one too. So anyways, please read through that. Now we have the TZDs, thiazolidinediones. Easier for me to say the TZDs, that's an abbreviation for it. They're also, you can think of them as being insulin sensitizers, but TZDs for testing purposes. So we have a couple that are left on the market. This one was pulled from, so just FYI. But these activate the PPAR gamma receptor, and they basically help enhance glucose uptake with the skeletal muscles and decrease new glucose being produced from the liver, is the take-home point with those. Adjunct medication used for type 2 diabetes, especially if they have insulin resistance, because they are insulin sensitizers. Rare but serious adverse effects here. You can go and list those. Look through those rather. This last one too, heart failure, is related to a box warning, so please make sure you pay attention to that. Read through this slide, please. But CHF is an issue with these medications, and definitely something you have to be mindful of when you're using these medications. Next, we have the alpha-Glucosidase inhibitors. Couple of those, the acarbose and the Meglitol, and what they do is, what their mechanism of action is related to how they are categorized, so pretty straightforward as for studying purposes, but they inhibit the alpha-Glucosidase enzyme in the liver, enterocytes of the small intestine, not in the liver, but yeah, then they help lower postprandial glucose. Again, can be used more of an adjunct for type 2 diabetes, and we'll go into where they fit as far as first line, second line and stuff. We'll go into that in another lecture. Adverse effects, mainly GI adverse effects, common adverse effects there. Slow down to say that. Amylinomimetic. It acts like amylin. So we have this one here, the Meglitide. This one is actually given subcutaneously, and it's basically a synthetic analog of amylin. So it works just how amylin would in your body. So go ahead and read through the mechanism of action there. Use adjunctive treatment for type 1 and type 2 diabetes. Adverse effects, you'll notice the hypoglycemia is there again. And then the nausea. This one also can have some beneficial effects on weight and can cause some weight loss. All right, here's where we get to not match this table a little bit. So you can go ahead and cross this out if you would like to. I think it'll make it easier from now on. So I have this here. This is from a vintage arcade game, Super Hang On or Hang On. I don't know if you guys remember that arcade game or playing that. But so just hang on here, and we're going to get into some new categories they're newer anti-diabetic drugs that weren't in this textbook that I pulled these from. So just hang on. If you could please add these to your tables for studying purposes, etc. Okay, first off, we have the gliptins, which are DPP4 inhibitors. So peptidyl peptidase 4 inhibitors is the long name there, but also known as gliptins, and then also known as DPP4 inhibitors. I have to slow down because I always want to go DPP. I want to DPPP. I want to add like so many P's when I say that, but so I usually just call them gliptins so I don't add too many P's. I don't know what, I just go, like once I start saying DPP, I just have to add like more and more P's. But anyways, okay. So gliptins, because they all end in the gliptin ending, so that's just kind of what I. But for testing purposes, the DPP4 inhibitor is, you know, what will be officially on the exam, or what I'll be referring to them in test questions. You'll notice here the generic is in a bold, and then we have the brand names here listed for you guys. Again, just FYI, the brand names, and the reason why is because I feel like you hear Januvia more than the sitagliptin, for example. You hear people say, and some of these are combination medications, some are extended releases. So like the Janumet is Januvia plus metformin, which I have a slide later, and it breaks down all the combinations. And the combinations are going to be FYI, you know, you don't have to worry about memorizing these. And again, you're not responsible for the brand names for testing purposes. Mechanism of actions, but like the category says, they inhibit the DPP4 enzyme. So what does that mean? It increases the incretin levels. So go ahead and read through all this, but so beneficial for type 2 diabetics. That kind of simplifies the mechanism of action here. So basically this enzyme that's being blocked destroys incretin. So it helps increase incretin. And what does that do? It helps the body produce more insulin only when needed, and then helps reduce the amount of glucose produced by the liver when it is not needed. So overall should be beneficial, right, for your diabetic patients. So they do have a protective effect on the heart, so that could be a potential benefit of it. And then as far as the expected A1C reduction, 0.7%. So not a giant swing, but a little bit there. This also too, please don't, I've had students ask me before, you don't need to memorize these percentages. It's just more of an FYI for you guys, this slide. I mean, the heart protection is good, but as far as the A1C specifically is FYI. Dosages here, it's something newer. We're trying to incorporate some more, but don't worry about it for this exam. This is just more FYI. I just wanted to, I came across this information, and I'm trying to kind of beef up slides and stuff. But anyways, long story short, you can put FYI on here. You will not be responsible to memorize the cost nor the dose. Just know that, you know, it's just FYI. It's usually once a day, once daily dosing, which is nice for patients. They are expensive though. These are newer medications, aren't generic, so you notice the expenses there. Side effects. So pancreatitis is one that you definitely need to put a star by and make sure you know about that. And then heart failure with specifically these two medications. The sitagliptin does not increase these cardiovascular effects. And then with the linagliptin, they're not sure yet. It's one of the newer ones. They still have ongoing studies unknown. So the heart failure, please tease out and make sure you know which one specifically you have to worry about them, you know, being an issue. More adverse effects here. You'll notice the headache, dizziness. Hypertension can be an issue. Again, especially if a person already has issues with hypertension, or, you know, so that's something to be mindful of with these medications. Here's some advantages of this medication. It is weight neutral, so you won't have to worry about them gaining weight when they're on this medication. Lower risk of hypoglycemia when it's used as a monotherapy, so that's good. Typically, it's well tolerated. I mean, definitely note those adverse effects like the pancreatitis I talked about before. There are some potential heart benefits, so go ahead and read through those there. But, and it's interesting too, because specifically sitagliptin has reduction in blood pressure, but then, you know, as a class, you have to be, it has the potential for hypertension. So sitagliptin of the ones would be your drug of choice to go with if someone did have hypertension and you weren't interested in starting them on this. And then because it does reduce blood pressure, you would need to be mindful of it. If there aren't other blood pressure medications, so those need to be adjusted, etc. So anyways, next up we have the glucagon-like peptide 1 receptor agonist. Unfortunately, there's no like cool nickname for these, but the GLP-1 agonist. So make sure you categorize them that for studying purposes. Generics here on the left. I don't know why I didn't put them in bold, but anyways, generics here, and then in parentheses are the brand names. These, like the category says, they're agonists of the GLP-1, which is going to help increase your insulin secretion, decrease glucagon secretion. It increases the beta cell growth, replication, so that can help, slows gastric emptying, and decreases food intake. So all that approach should be beneficial for the type 2 diabetic patient. So in other words, kind of a more simplified mechanism of action, increase insulin secretion and slows gastric emptying. So that's definitely a take-home point for mechanism of action. So hopefully that'll make it easier for studying purposes. Again, average decrease in hemoglobin A1C, you notice it's bigger than the DPP-4 inhibitors that we just talked about there. But again, this will be FYI. You don't need to memorize that. Average weight loss, which can be beneficial. You notice it is in kilograms, so you need to convert that to pounds if you're thinking or wanting to tell your patients, since most patients don't understand kilograms in this country. But so that can be a big advantage there, again, depending on your patient, if you're interested in having them help with weight loss. Adverse effects, GI adverse effects. These are injected medications, so you do need to be worried about injection site reactions. That can be an issue. The other thing too to note is that Byetta, or the exenatide specifically, brand name or generic for Byetta, cannot be used in severe kidney failure. And then also too, this one does need to be adjusted renally, or rather do dosage adjustments dependent on the renal function and if they have renal impairment or not. So that is something to note. This is just, again, FYI, the cost. I'm not going to test you guys on this, but just know that they are expensive. You'll notice here. Positive or negative effects on the heart. Basically, long story short, they don't know exactly, so they're still kind of looking into it. You can read through here. We got some bullet points there on where it may be the Victoza may be have some benefit. Same thing with these. Just read through them. So this is just an FYI. This one too. It's just basically saying, kind of stay tuned. When you're on rotations, you're out on a practitioner, it might be something you want to follow up with, see what kind of the new data says, new research says about these. Dosages. So, again, just FYI, like I mentioned before, these are injectable. It is a subcutaneous injection. So this is once a week, so that could be good for patients that don't have to inject themselves as frequently. Same thing here, sub-Q injection, which is SC, so what that stands for. Q week. Same thing here, just FYI on these dosages. I just put it in there just so you can kind of get an idea. And again, like I said, I think it's going to be something we're going to be doing more in the future, but just wanted to show you guys that. You can just definitely read through these and it may be helping. They do make some combinations too, so that you'll remember from previous lecture, the insulin Degludec is a long-acting insulin, and they do make that in combination with this GLP-1 agonist here. So just know that is something that they make. So this one, don't stress about memorizing it. And I know there's a lot going on here on this, but just read through it. It's just more FYI for you guys. Same thing here. The insulin glargine, is also another long-acting insulin that can be mixed with, or remember that comes commercially available product, brand name here, that with a GLP-1 agonist. You just read through that. The advantages for this and why they are thinking that, or why this is a good idea, why they make these, is that it can help prevent having to increase your basal insulin dose. And then there's less weight gain with similar hypoglycemia risk. But a lot of disadvantages here. So, I don't know, it's going to kind of depend on which physicians you're with and who you're ultimately practice with. But these are very expensive. So that's a big issue, and insurance companies might not pay for them, and cash paying patients may not want to pay for them. So there's also retitration, so that can, can kind of make switching over be a little bit more difficult. It also, one of the limitations is that you cannot be used if a patient does need a higher basal insulin dose. So that long-acting dose is kind of maxed out depending on your product. The other thing to note too is that with the cardiovascular risk, these aren't created equal, these two combination ones. So that's just more FYI. This was just an interesting, so this is the GLP-1 agonist versus the DPP-4 inhibitors. You notice they're listed here. It was a study done in 2008, and it just basically showed that the GLP-1 agonist was maybe better for lowering the postprandial glucose, increasing insulin levels, decreasing glucagon levels, and decreasing caloric intake. So that is something to think about. And then here's another study too, and just go and read through this. Both of these slides too. I don't expect you guys to memorize or anything. It's just more FYI slides in there. This slide I would pay attention to, and it is kind of a reason why to pick one over the other. So why would you pick the DPP4 inhibitors, which are called the gliptins, over the GLP-1 agonist? So with the gliptins, typically it's going to be an older population that you're going to want to stick with. It's safer to use in impaired kidney function, which is one of the reasons that it is preferred in the older population, because typically older people have impaired or decreased kidney function. So this is going to be a safer choice for that. Neutral effect on caloric intake, which again, with an older population, even if a person has type 2 diabetes, you may not want them to have reduced caloric intake just because weight loss can sometimes be a negative issue, or rather be a negative kind of factor with an elderly population, depending on the specifics of the patient. And it does have a confirmed effect on lowering blood glucose versus the GLP-1 agonist, so younger population preferred. So your newer onset, recently diagnosed, a person who is overweight, and you do maybe want to help them lose weight, and then definitely someone who has better kidney function because of the adverse effects as far as these can have with and need to be renally adjusted, their dosages. Next, we have the flozins, which are sodium glucose cotransport 2 inhibitors, or SGLT2 inhibitors. Flozins, easier to say, they all end in flozin. So again, generics here, brand names over there. Mechanism of action, so it's like what the category says, which is really nice for studying purposes, I think. They are SGLT2 inhibitors. That's what they do, take home point. And so what does that mean? That means that you basically pee out extra glucose. Again, read through this, it says it better than what I just said, but you basically increase urination of excess glucose. Like I said, you just pee out the extra glucose. Here's the expected A1C reduction. Again, just FYI. Dosages and costs, so they are pretty expensive, but just FYI for you guys for this test. Adverse effects, you'll notice a lot of them are related to the GU, to the urinary tract system. So UTI is an issue, genital fungal, yeast infections for male and female. You'll notice that's dizziness, low blood pressure, that can be an issue. Common adverse effects. Fractures are rare. Increased risk of bladder cancer, rare. Ketoacidosis, rare. So these are all rare but serious adverse effects. Acute kidney injury as well, rare but serious adverse effects. Amputations too, this is another rare but serious one. This is actually related to a box warning, which is interesting. And here is the specifics for that. So they actually, as recently as May 2017, they released a special alert. The FDA had a special alert related to this. And before that, these medications are specifically, Invokana, which is here, specifically had the lower limb amputation box warning. So make sure you guys read through that and look at that. Some advantages to these, they do help with weight loss. So that is something to be thinking about. Also too, they can have some beneficial cardiovascular effects. So you can go and read through that. And as promised, we have the combinations. I'm at the Pizza Hut. I'm at the Taco Bell. I'm at the combination. No, I'm not going to sing for you guys. I don't know if you guys heard that song. I always think of that when I think of combinations. So there are just for FYI, you do not need to memorize these, but I definitely wanted to show you that they are a ton of combinations that they make. And so these are the generics or the chemical names, and then these are the brand names here. Again, like I mentioned, the sitagliptin, metformin, Janumet combination. And then anytime you see an XR, by the way, it just means extended release. So it's a, so you dose it maybe once a day versus twice a day. It's a longer acting preparation. So you notice I put 3 slides of combinations here. So just read through them. Like I said, I'm not going to test you guys on these and make you guys responsible for them, but you will be probably seeing these out on your rotations and then out in practice. Here's a summary. All right, here's a summary slide. I was trying to combine summary and slide to a slummery, but no, summary slide. Let me speak slowly and enunciate. Summary slide. of some of the drugs, insulins, clinical applications, adverse effects, contraindications. Please read through those, look through those. You will not know, they will not be those newer medications that we talked about past that that video game slide I had. So those won't be on there, but just what I had on the slides is just focus on those for those medications. Last but not least, we have Glucagon. This is a hyperglycemic agent. So this one, so this medication will help when a person has severe hypoglycemia. You know, we talked about insulin, and then some of these other medications can cause hypoglycemia. So, and it can be a major issue. So this will be used in an emergency situation. They make an IV, IM preparations of this. In addition, they make a sub-Q preparation. So the 3 different preparations, IM, IV, and subcutaneous preparations of this. So it can be administered if a person is in hypoglycemia. So because of that, it is used to treat severe hypoglycemia in pediatric and adult patients. And then there is this ADA recommendation here that that there is glucagon prescribed for all diabetic patients that have significant risk for hypoglycemia, but then also to caregivers, school personnel, family members. The patient should be trained on when and how to administer the glucagon. So if a person is having severe hypoglycemia, then they should be administered the glucagon. And just for example, here's one that's manufactured by Lilly. So it's a glucagon emergency kit for low blood sugar. And you notice it's an injection here that comes with pretty simple to understand and directions. But anyway, so that's interesting to note there that it is an ADA recommendation now that everyone is aware of that and trained. It can also be used as a diagnostic aid because it slows down the movement of the GI tract, or inhibits actually the movement. Also can be used for treatments of overdose of beta blockers and calcium channel blockers. So it will help correct the myocardial depression caused by those 2 classes of antihypertensives. So there's the uses there. That is the last slide from me. Yes, it is. Okay, last slide from me. So thank you guys for your time and attention, for paying attention, and for fast forwarding through this whole video. No, but yeah, thank you guys for that. Please feel free to email me comments, feedback, questions. Let me know if anything wasn't clear or whatever. If you have anything to be further elucidated. And that is it. Thank you guys. I'll talk to you later. Bye.